Good evening, everybody. Welcome to this evening episode of Pursue, and we have Pursue 6R, which is liver and GI pathology, and we are streaming live from UCSF USA via Kolkata. And we have two very eminent personalities, Dr. Munita Bal, who is the head of pathology at the Department of Pathology, Tata Memorial Hospital, Mumbai, and she is instrumental in defining various courses in TMH Mumbai and is the person responsible for liver and GI and head and neck pathology at TMH Mumbai. She'll be moderating and she'll be introducing Dr. Sanjay Kakar. So Dr. Munita, please take over and please introduce Dr. Kakar and we'll start from there.
Thank you so much, Dr. Nadeem, for the kind introduction. Now, I have a very pleasant job of introducing Professor Sanjay Kakar, who, in my opinion, does not need any introduction for the pathology community, but for the students and beginners, I would say that Professor Kakar is a master and an authority in GI and HPB tumors. He's a towering figure in this vast field, a teacher par excellence with a sterling career lit with many accomplishments. I'm very proud to say that he did his MD from PGI Chandigarh in 1994 and thereafter moved to the US, and now he is the chief of the GI HPB service in UCSF San Francisco. He's the director of the fellowship program there in the GI HPB and staff pathologist in the VA Medical Center San Francisco. It will take me a whole day to go through his achievements. Suffice it to say that all the reporting protocols, guidelines that we follow religiously every day, he has been a part of them all. He's led them. He has been president of US GI Pathology Society, vice president of Hans Popper Society, member of the AJCC on GI and HPB, ICCR, HCC expert. He's a CAP Cancer Committee member. He's the lead author on all the colorectal and HPB protocols. So practically everything that we follow in GI has been led by him, or he's a part of it. And he's editorial board. He's on the editorial board of Human Pathology and World Journal of Hepatology, and has many international publications in top journals. And the best thing about him is his deep humility and his wonderful nature. So today I'm very excited to be listening to him and learning from him. So please take the stage. It's all yours.
Good evening, everyone, and thank you, Dr. Munita, for such a generous introduction. I thought you were introducing somebody else. And I would also like to thank Dr. Nadeem for inviting me. And those of you may not know, Nadeem is like my childhood friend, and not literally speaking, but we spent started our career in pathology together in PGI. And this is an excellent effort by Dr. Nadeem putting this series together and this resource out there in the internet for everybody to use. Okay, so let me get this figured out.
Just press present now.
Yeah.
And then your entire screen and then share the screen.
Yeah. So you can see my screen now?
Yeah, we can see your screen. Yeah, it's on the way, yeah.
Yes,
yeah.
You can see.
It's there.
Okay. All right.
Please start.
So we're going to talk about some challenges in some selected liver tumors. You can divide this topic into some selected areas which are common problems in diagnosis of hepatocellular carcinoma, cholangiocarcinomas. At the well-differentiated end, HCCs have to be distinguished from adenomas and FNH and so on. And there are non-epithelial tumors which can also mimic HCCs or sometimes even cholangiocarcinomas. So this is the part one, and I'll be doing another session maybe a couple of months from now. And for this session, I'm going to focus on these three main areas. So in the beginning, we'll go very briefly through commonly used markers, and this is mainly for the workup of hepatocellular tumors. And this will be like a brief introduction into the advantages and some of the pitfalls of commonly used markers. And I will suggest a proposed algorithm, which is maybe not applicable in all cases, but it's helpful to think about liver tumors from that perspective. And then in the major portion of this session, we will go through case examples, and I'm going to focus on cases beyond HCC and cholangiocarcinomas today, and maybe in the next session we'll focus more on hepatocellular carcinomas and cholangiocarcinomas and some of their close differential diagnosis. So let's start with a brief review of the commonly used markers. So here is a list of 4 of the hepatocellular markers which are commonly used. And we are all familiar with HepAR1. It has high sensitivity and specificity for hepatocellular carcinomas. Some of the limitations to keep in mind are that a serous HCC and poorly differentiated HCC, the sensitivity of HepAR is lower. And in some of the adenocarcinomas, HepAR is known to be positive, especially in gastroesophageal and lung adenocarcinomas, and less commonly in a variety of others. So here's an example of a gastric adenocarcinoma, and you can see a diffuse, strong positive staining with the HepAR. Now, arginase 1 is a urea cycle enzyme, and as we know, urea synthesis occurs only in the hepatocytes. So arginase is specific for hepatocellular differentiation. And the advantages of HepAR are that it has much higher sensitivity and specificity, including serous HCCs and poorly differentiated HCCs. No marker is perfect, so it can be negative in selected around 10% or so of HCCs, and rarely in other adenocarcinomas. I know that from discussions with people who practice a lot of liver pathology in India, I have found out that arginase 1 for some reason does not work that well in the Indian setting. And I'm not sure what exactly the reason for that is. And I do plan to get some of the arginase negative cases from there and just try them out here to see what might be the reason for the discrepancy, that there's much lower sensitivity. So you should keep that in mind when you're selecting hepatocellular markers for HCC. Here's a rare example of an intrahepatic cholangiocarcinoma. And you can see that the HepAR is, or the arginase 1 rather, is very strongly positive in the tumor cell. But this is quite a rare phenomenon, and in a vast majority of cholangiocarcinomas as well as other adenocarcinomas, arginase 1 is either negative or just shows some focal stain. We are familiar with Glypican-3 as a marker that can be used for HCC. It's an oncofetal antigen. The advantage that it offers is that it is more sensitive in cases of serous HCC and poorly differentiated HCCs. And since it is an oncofetal antigen, it is not expressed in benign hepatocellular proliferations like adenomas and FNH. The downside of it is that it has a much lower sensitivity, perhaps less than 50% in well-differentiated HCCs. And the other thing to keep in mind is that Glypican-3 is not really a hepatocellular marker. It's an oncofetal antigen, and it can be expressed in a wide variety of malignant tumors, especially in germ cell tumors. So here's a study which examined Glypican-3 expression in more than 4,000 cases, and you can see a long list of tumors that can be positive for Glypican-3. Hepatocellular carcinoma is still the most common, around 2/3 in this study, but then you can see a lot of other tumors. A lot of them don't enter the differential diagnosis of HCC, but some of the notable ones, you should keep in mind, like melanomas can be positive, and some of the adenocarcinomas can be positive. Virtually any malignant tumor can be positive. So you have to keep in mind that if you're making a diagnosis of HCC based only on Glypican-3 staining, when other hepatocellular markers are negative, so you have to be very careful in that situation. So here's an example of a poorly differentiated HCC, which is HepAR1 negative and strongly positive for Glypican-3. So that's one of the advantages of this marker in identification of poorly differentiated HCC. Here is the cirrhotic nodule, and you can see that there is no evidence of HCC in this case. So patchy staining with Glypican-3 can be seen in cirrhotic nodules, also in livers which have a very active inflammatory activity. So you can see Glypican-3 staining in that setting as well. And the last marker on this list is a polyclonal CEA. And CEA typically marks adenocarcinomas, but if you use the polyclonal antibody, it cross-reacts with the glycoprotein in the canaliculus, and that's why you get this characteristic canalicular pattern of staining, which is thought to be specific for HCC. And the limitations of this marker are that it can be difficult to interpret canalicular versus membrane staining that you can get in adenocarcinomas. And like HEPAR, it has lower sensitivity in squamous as well as in poorly differentiated hepatocellular carcinomas. So here's an example showing you the characteristic canalicular pattern of staining with HCC. So what you want to look for is this kind of a branching configuration where that's how the canaliculi are. So you can see that's a kind of a V-shaped or T-shaped pattern of staining. So that's what you're looking for, not complete membrane staining, which is more characteristic of adenocarcinomas. And you can also see this kind of luminal accentuation with adenocarcinomas. And in some cases, it can be difficult to distinguish from canalicular pattern of staining. So that's why I think polyclonal CA is a useful marker, but probably not like a first-line marker for the diagnosis of HCC. So a variety of other markers can also be used. And the AFP has much lower sensitivity, and all these markers, Willen, CD10, and BSEP, all these show pattern which is similar to polyclonal CEA. They have a canalicular pattern of staining. With the TTF1, depending on which clone you use, you may get cytoplasmic staining, not nuclear staining like you get in pulmonary adenocarcinomas. And this is very similar to HEPAR1. And so it really doesn't offer any advantage, but you just have to be aware of that in case you come across this clone being stained, and hepatocytes as well as HCC will show cytoplasmic staining. CD34 we know can show diffuse sinusoidal staining, but is not specific. And more recently, albumin in situ hybridization has become available. And we know that albumin is synthesized only in hepatocytes. So if you look for mRNA, it should be present only in the hepatocyte. So that has served as the principle for this assay. But albumin in situ hybridization is positive in both HCC as well as cholangiocarcinomas. So it serves as a useful marker for primary hepatic tumors, and it does not distinguish between the two.
Can you just press that hide so that the pop-up can go away, please? Sorry for interrupting. Just press the hide thing here. Sorry.
Nadeem, I didn't hear what you said.
Yeah, just press that hide thing so that that pop-up just goes away, because it's
Okay.
Thank you. Sorry for bothering.
Oh yeah, no problem. So albumin in situ hybridization, as this table shows, is positive in more than 90% of reported cases of HCCs, and in intrahepatic cholangiocarcinomas, around 2/3 of them will show staining with albumin in situ hybridization. Other tumors less commonly can be positive, especially pancreatic acinar cell carcinoma. And that, in my experience, it can be very strongly positive for albumin in situ hybridization. So here's a table from a recent publication showing you the whole range of tumors that can be positive. If you go on the spectrum, which are 3+ or 4+ positive, so strongly positive, it's only in HCC and cholangiocarcinomas, but patchy staining or weak staining can be seen in a variety of other tumors as well. So here's an example showing you the granular staining in HCCs with albumin in situ and intrahepatic cholangiocarcinomas, which they can be more diffuse as well, but I chose a case to show you because most cases will show this kind of more patchy but quite strong staining in the tumor cells. On the other hand, we often use adenocarcinoma markers when they're not really specific for adenocarcinomas, but they're more common in adenocarcinomas. And a variety of them, like MOX31 antibody, CK7, CK19 can be used. And most adenocarcinomas, neuroendocrine tumors are positive, but a variable number of HCCs will also show positivity with these markers. Pancytokeratin, if you use a cocktail which has been properly titrated, it will be positive in most of the hepatocellular carcinomas. So here's an example showing you hepatocellular carcinoma, which is showing MOC31 staining, and another example of HCC with the CK19 positivity. So this is seen around 10 to maybe 20% of HCCs, and CK19 positive HCCs have been associated with more aggressive clinical course. So with this background, let's examine a case to see some of the highlights or pitfalls rather of these immunohistochemical markers. You may have seen this case if you've seen one of my earlier presentations, and I really like this case because it really illustrates some of the limitations of these markers very well. So this is a 66-year-old who had a 6 centimeter liver mass on imaging. There was no other liver tumor, and you can see a small portion of a non-neoplastic liver here. And here you have a tumor which is more compact. Other areas of the tumor had more fibrous stroma. Here's a closer view of the tumor, and it's composed of these polygonal, very hepatoid-looking cells with moderate to abundant eosinophilic cytoplasm, and these are arranged in nests or somewhat in trabecular formations in some areas like here. Another closer view of the tumor, which highlights this nests and trabecular tumors. It's frequent mitotic activity, and in some areas you can see sort of acinar-like formations as well. So given the fact that this is in the liver and this has this polygonal cell or hepatoid look to it, the workup included hepatocellular markers, and you can see that a hepar is positive, showing very strong staining in some tumor cells and more moderate staining in many of the others. And here's the profile that this case was sent with. These are the stains that were sent when this case was sent to us. So you can see hepar was positive, and some of the other markers that were done were negative. TTF1 was done because there were lung masses as well. So the question at this point is, you have a hepatocellular looking tumor, which is hepar positive, and there's no other mass lesion based on imaging. So what is the diagnosis? Are we done? Is it a hepatocellular carcinoma? Or is it possible that we are dealing with a non-hepatocellular tumor, which is showing aberrant staining with hepar? So what I like to advocate is a mesothelioma-like approach in the diagnosis of liver tumors. So in mesotheliomas, the standard practice is to use 2 mesothelioma and 2 adenocarcinoma markers because of the lack of fidelity of these markers. And the same principle applies in the setting of hepatocellular tumors, that these markers are not specific. So we should be using, especially in the setting of non-cirrhotic liver, 2 hepatocellular markers and 2 markers that are more common in adenocarcinomas for proper classification. In some settings, such as cirrhosis, or in if morphologically you're seeing bile production, then you probably don't need a more extensive immunohistochemical workup. But in most settings, it's helpful to combine 2 markers from each of these categories. And you can pick up the markers based on what is available to you and what you have experience with. As I mentioned, arginase 1 may not work that well in the setting in India, so you can choose 2 of the other markers. I typically choose arginase 1 and hepar 1. If it is poorly differentiated, I might add clipican 3 as well. And then from the other column, I typically do use CK19, and then any one of the MOC31 or CK7 would work well. So if we try to apply this approach in the case that I showed you, and 2 stains were added, so it was hepar and CK was positive, CK7 negative. So we added arginase and MOC31, and you can see that it was arginase negative, and MOC31 was strongly positive. So what are we left with now? So it's possible that it's an arginase negative HCC, or it's a non-hepatocellular tumor which has an aberrant HEPR1 expression. And as I mentioned, you can see that in a variety of adenocarcinomas and less commonly in neuroendocrine neoplasms. I haven't really seen that with renal cell carcinomas, but I'm sure that rare HEPR1 staining can be seen in a wide variety of tumors. So based on this somewhat aberrant pattern of staining, additional markers were obtained, and this tumor was very strongly positive for both chromogranin and synaptophysin. And although a clear primary site was not evident, there was some vague lesion in the pancreas. This was evidence of a neuroendocrine carcinoma which had an aberrant HEPR1 expression. So I know that there's already been a session on the neuroendocrine neoplasm, so I'm not going to go into detail into neuroendocrine carcinomas. But what I want to emphasize, especially based on this case, is an approach of viewing hepatocellular tumors based on the results of two stains. So one hepatocellular marker and one marker which is more common in adenocarcinomas. And among the hepatocellular markers, I have used arginase 1, but you can just replace that with HEPAR and CK19. So if you just use those two stains and divide the liver tumors, then you can only have four possible categories, right? So you can have a tumor which is arginase negative or HEPAR, arginase positive or HEPAR positive, and CK19 negative. And in that setting, it would be a hepatocellular carcinoma unless it is, clinical or radiologic findings are aberrant. So in vast majority of cases in group 1, we are dealing with HCC. So group 2 would be if it's negative for arginase and positive for CK19. And in a vast majority of cases, this would be likely a non-hepatocellular tumor adenocarcinoma. It could be a neuroendocrine, or it could be one of the other carcinomas, or it could be one of the hepatocellular carcinomas, which is arginase or HEPAR negative, depending on which one you're using. So group 3 would be positive for both CK19 and arginase, and in a vast majority of cases, this would be a CK19 positive HCC. And then there is group 4, which will be negative for both arginase as well as CK19. And this is a very diverse group of tumors. And this is actually one of the most interesting group as well. And you can divide this group into two broad categories. So if you do a pan-cytokeratin stain, the arginase negative or HEPAR negative and CK19 negative tumors will fall under kind of two categories. The keratin positive ones would still be HCCs and some of the other carcinomas which have kind of polygonal cell morphology, adenocarcinomas, neuroendocrine, renal cell carcinoma. Less commonly, urothelial and squamous cell carcinomas can metastasize to the liver. But it's the keratin negative category that you really have to be very careful about. And these tumors can very closely resemble HCC morphologically. And if you don't think about it, these can easily be overlooked. So by dividing these tumors in the liver into these four groups, it can be very helpful in deciding which path you want to follow with additional workup, or if additional workup is even needed. So let's look at some of the examples illustrating this approach. And before I start doing that, I want to ask you this very important question. And I know we can't have feedback or polls, but I really want you to think. And if you want to be a good liver pathologist, you really have to be able to answer this question. And the question is, what do gnomes and elves have in common? So you might be thinking, like, what kind of crazy question is this? You've seen gnomes and elves in all kind of fairy tales, but what does this have to do with liver pathology? Well, gnomes and elves, the thing that they have in common are that they are great liver pathologists. And if you're not aware of this, I would refer you to this recent article that was published as a review of a history of liver pathology. So there was an international liver pathology group that was formed, and that was like nearly 50 years back, with all the great names that we are familiar with from our textbooks. And they formed this group, and this group came to be known as the Gnomes. And they would meet together and brainstorm about liver pathology, share cases with each other. And this was kind of a closed group. They were maybe a group of like 15 pathologists or so, and this was an international group. So the next generation of pathologists who came along, they were really inspired by the Gnomes group, and they realized that they can't find entry into Gnomes because they didn't want the Gnomes group to become too big. So they formed a new group, and they called it the Elves. And people who mentored me, they are all part of Elves. One of my mentors, Linda Farrell, is part of the Elves group, and they continued the tradition of meeting at regular intervals, sharing liver pathology cases, and publishing some review articles off and on as well. So I was talking one day, this was many years ago, with some of my liver pathology colleagues across the country, and we decided, we should also form a group. So we started thinking of names, like what names should we come up with. So we came up with a variety of different names, like goblins and so forth. But so, these are very benign-looking gnomes. Elves. They sound very friendly. We have to sound a little more aggressive. So we came up with the name of gremlins, and so here's some of the names that you will recognize. So we formed this kind of informal study group to exchange ideas and to do some studies in liver pathology. And I encourage all of you to form such or similar groups with like-minded people. It really is very stimulating to have discussions with the friends and colleagues across the country about different ideas and how to pursue them. Okay, let's proceed with another case. So what I'll do is I'll maybe show you another 2 or 3 cases, and then I'll take a break and take some questions from you, and then we can keep going. So this is continuing on the theme that I started with of liver tumors which are going beyond HCC and cholangiocarcinoma. So this is a 35-year-old with a history of IV drug use. This patient died in a car accident, and the organs were being considered for transplant. And while this was being done, a 4-centimeter liver mass was noted by the surgeon and was sent for frozen section. And the pathologist who reviewed the case, so this is what the pathologist saw, that this was a tumor which had somewhat of a polygonal cell appearance. Maybe you can imagine some trabeculae here, and some moderate amount of cytoplasm, not much in terms of cytologic atypia. And here's a closer look at the tumor. So based on this, a diagnosis of hepatocellular adenoma was rendered at the frozen section. This was a young woman, and a variety of organs, including the liver, kidneys, heart, and I think even lungs, they were transplanted to multiple donors. And following that, a couple of days later, the permanent sections from the frozen came along, and then this is the permanent H&E section. So you can see somewhat similar features. So kind of polygonal cells and mostly arranged in kind of sheets without any specific pattern. But then some of the areas started showing this necrosis. And then here's a closer view, some minor atypia, not very marked atypia, but you can see some pleomorphism, prominent nucleoli. So the pathologist started to get a little worried. And here's another view, there's a mitosis also. So at this point, the pathologist was worried that this might be hepatocellular carcinoma, and multiple organs had already been transplanted by this time. So the pathologist got a reticulin stain and was even more worried now, because you can see there's hardly any reticulin framework in this tumor. And then additional workup, the glutamine synthetase stain was obtained, and this stain is a good marker for beta-catenin activation. If you see diffuse and strong staining, as you're seeing in this case, it's a marker of beta-catenin activation, which you can see in hepatocellular carcinomas and in adenomas, which are considered to be high risk. So at this point, the pathologist was really worried that this might be a malignant tumor, and it had been already the organs had been transplanted already. So this is the point that the case was sent for consultation, and I got the case for review. So let's see what the additional workup showed. So the hepatocellular markers are actually all negative in this case, and even the pan-cytokeratin was negative. So let's go back to our table that I showed you for both hepatocellular marker negative and CK19 negative tumors. So we are in this category of keratin negative tumors now. And a lot of these tumors are fairly ominous. If you have a melanoma and you have transplanted all the organs, that's very ominous. If you see some of the literature, there have been many horror stories of transplanted organs developing metastatic disease after occult disease that was not known at the time of death, and multiple organs have been transplanted. So you have to be very careful in the evaluation of frozen sections in such situations. Additional workup, although showed that this tumor was positive for HMB45 as well as smooth muscle markers, so smooth muscle actin was positive. And that clearly established the diagnosis of an epithelioid angiomyolipoma. So epithelioid angiomyolipoma can very closely resemble hepatocellular tumors because the epithelioid morphology resembles like epithelial tumor, and these tumors in the liver can often be monotypic. That is, the angio component or the lipo component may not be very clearly apparent. So some of the features that can help on H&E is that these tumor cells often have indistinct cell borders. You can see they are kind of merging into each other, and that's apparent even at low power. And you can see they kind of streaming look to it, which is different from epithelial tumors, which appear kind of more compact and more well delineated. And you can also see some spindling of the tumor cells. So this is a very common feature, even in epithelioid angiomyolipoma. If you see foci of extramedullary hematopoiesis, that can be helpful. It's a feature in some of these tumors. And sometimes you can get a collection of these foamy histiocytes in angiomyolipomas, which it's not a specific feature, but it can help you alert to this diagnosis. So once you think about it, the diagnosis is actually very straightforward because the immunohistochemistry is highly characteristic. It's keratin negative, and it is in the family of the perivascular epithelioid cell tumors or Pgimer. And these tumors characteristically show myomelanocytic differentiation. So you will see a positivity for melanocytic markers, HMB45 and so forth, as well as myogenic markers. And that's a very characteristic profile. Now, S100 is negative in these cases, so that helps in distinction from melanomas. And as I mentioned, keratin is negative as well. So in rare cases, you can see TFE3 positive. This is one of the more recent subtypes that has been reported for angiomyolipoma, but this is very rare. So I'm just mentioning it so that you are aware that a small subset will show translocations involving the TFE3 gene, and they can be positive immunohistochemically for TFE3. Now, what about benign versus malignant? As I mentioned in the case that I showed you, this patient had organs transplanted, multiple organs that had been transplanted. So should we be worried that angiomyolipoma case has been a source of organs for these multiple patients? So in a wide variety or wide majority of cases, these tumors are benign. I would say more than 95% of hepatic angiomyolipomas are benign. But the criteria for malignancy are not very well defined. The large size, atypia, necrosis, and so forth have been suggested, but none of them really pan out because a lot of these features are seen in tumors which behave in a benign fashion. Now, there's a study of 35 GI angiomyolipomas or Pgimer, which came up with these criteria for malignancy. But these are present in up to 1/4 of cases, even without metastasis. So cases which do not show malignant outcome can also show many of the features that define the malignant angiomyolipomas. In the case that I showed you, it had necrosis, but it was a small tumor. It did not have much in terms of atypia. So in all likelihood, the prognosis was that it's going to behave in a benign fashion, although there's no guarantee for that. And even perfectly benign-looking angiomyolipomas in the liver have been known to recur and metastasize. So you always have to keep this possibility in mind that every angiomyolipoma is potentially malignant, even though it's a very rare occurrence. It's also useful to know that angiomyolipomas, the malignant ones, some of them anecdotally have been very successfully treated with mTOR inhibitors. So let's go on to the next case. This was an angiomyolipoma that I showed you. So the next one is an 89-year-old with a history of gastric ulcer. And this was a 5-centimeter liver mass, and this is a needle biopsy. So on low power, you can see the sheets of tumor cells, which some of them appear to have either vacuole or some clearing of the cytoplasm. And here are some tumor cells. And there's no particular arrangement. They just appear to be in sheets of tumor cells. And let's take a closer look at them. Overall, mild cytologic atypia. A lot of them have these vacuolated cytoplasm and somewhat of a polygonal cell look to them, and no discernible arrangement, just sheets of these polygonal-looking cells with vacuoles. On low power, you could see that it's kind of encircling maybe some of the portal areas. And here is the immunohistochemical workup that was done. And you can see that the keratin is negative in these tumor cells. A wide variety of markers that were obtained, including hepatocellular markers, neuroendocrine markers, markers for renal, urothelial, and CK720, melanocytic, myogenic. All of those, that workup was negative in this case. And again, we are in the category of the tumors which are negative for hepatocellular markers as well as CK19. And we are looking at this column again of tumors which are very distinctive in their immunohistochemical profile. So you always have to think about them. And once you think about them, you can come to the diagnosis. And in addition to the tumors that I mentioned here at the top, you have to always think that sarcomas can have an epithelioid pattern. And these can very closely mimic carcinomas, including hepatocellular carcinoma. And this was the marker which was diffusely positive in the tumor cells, which led to the diagnosis. And this is a kit. And this was a case of actually metastatic GI stromal tumor. This patient did have an ulcerated mass in the stomach, which had been biopsied, and they only got the ulcer, and they did not biopsy the mass initially. And based on the liver biopsy, when the diagnosis of metastatic GIST was established. So let's look at another very similar looking case, or rather similar category of case, of a 72-year-old hepatitis C, tumor nodules in liver, lung, as well as bones, widely metastatic disease. Because the patient had hepatitis C, and the clinical suspicion, of course, was that this was HCC, which was widely metastatic. And here's a liver biopsy, which shows, once again, sheets of these kind of polygonal-looking tumor cells, kind of very similar theme that I've shown you so far today. And a closer look, you can maybe imagine some kind of trabecular arrangement, but mostly it's in large sheets or large nests of tumor cells. And once again, the atypia is not very striking. So overall, mild, at most moderate cytologic atypia. They do have a polygonal or hepatoid-like appearance, so this could easily be a hepatocellular carcinoma. And here's a reticulin stain that had been obtained, which shows that there's hardly any reticulin framework in this tumor. So the combination of this, as well as the history and the morphology, can easily lead you to believe that you're dealing with a hepatocellular carcinoma. But the workup for hepatocellular carcinoma was negative, and so was CK19. And once again, we are in this group of keratin negative tumors, and further workup showed S100 as well as SOC-STAM positivity. So this was a case of metastatic melanoma in a patient who did have chronic liver disease, and further probing of the history did reveal that this patient had a remote history of a skin melanoma that was removed many years back. So melanomas can metastasize after several years, and you also always have to keep that possibility in mind. So I'm going to show you this case, and then I'll briefly stop and see if anybody has any questions or comments for discussion. So this is perhaps a case which I think most closely resembles HCC. This entity can be virtually indistinguishable from it. And this is a 62-year-old who had multiple liver and lung masses, and this is a liver biopsy, and you can see a tumor that has this broad nests and trabeculae, and morphology is very similar in terms of the theme that I've shown today, that you see these round to polygonal cells and these very wide trabeculae, sinusoid lined by these sinusoids. So you can easily be dealing with a hepatocellular carcinoma, or the uniform nature of tumor cells indicate that it could even be a neuroendocrine tumor. And let's look at what the workup showed. So all the markers for HCC were negative, and synaptophysin is what is shown here, that it was a patchy positive, but it was pretty strong staining for synaptophysin in the tumor cells. The Ki67 proliferation index was 11%. And so the question at this point is that, are we dealing with a grade 2 neuroendocrine tumor, which is metastatic to the liver, or could it be a neoplasm which has neuroendocrine differentiation but is not a neuroendocrine tumor or neuroendocrine carcinoma, or are we dealing with altogether another tumor here? So once again, let's go back to our table. This case was not only negative for hepatocellular markers, but the keratin was also negative. And I showed you that the synaptophysin was positive, which is pointing towards neuroendocrine tumors, along with the morphologic appearance, which was very much like well-differentiated neuroendocrine tumors. But neuroendocrine tumors are almost always positive for pan-keratin. And you can see keratin negativity in neuroendocrine carcinomas, especially in a small subset of small cell neuroendocrine carcinomas. But in well-differentiated neuroendocrine tumors, it is unusual for keratin to be totally negative. It was totally negative in this case. So if we now move to the keratin negative category, and we have to keep in mind that the synaptophysin was positive. So we have several tumors here, or more than one tumor here in this category, which can be synaptophysin positive. So let's look at some of the additional workup that was done in this case. And here is an inhibin stain, which is showing some patchy, weak to moderate staining, and very strong nuclear staining diffusely in the tumor cells with SF1, or steroidogenic factor 1. And this is a very characteristic finding that you see with the adrenocortical carcinomas. And the metastatic adrenocortical carcinoma of the liver, a few cases that I've seen, they're virtually indistinguishable from HCC. And a couple of cases, there was no history provided of an adrenal mass when the liver biopsy was reviewed. So some of these stains that have been used for adrenocortical carcinoma include, melon A is positive, inhibin, calretinin can be positive, and all those have a variable sensitivity, and SF1 is probably has the highest sensitivity for this diagnosis. You have to be careful that SF1 is by itself is not diagnostic of adrenocortical carcinomas. You can see that in a variety of other tumors, such as sex cord stromal tumors as well. So you have to keep the overall context, including the clinical context, the morphology, as well as the overall immunohistochemical profile before you reach the diagnosis. Another point that I want to emphasize is that whenever you're dealing with these different diagnostic entities, you should ask yourself, what difference does it make? So, here we are dealing with a tumor that is positive for synaptophysin, and this was in fact initially diagnosed as a metastatic neuroendocrine tumor. So the question that you should always be asking in these different diagnostic considerations is like, what difference does it make? What is the impact? So whether you call it neuroendocrine tumor or adrenocortical carcinoma, how is it going to make any difference for the patient? So here's how it will matter. So adrenocortical carcinomas, vast majority of them have spread beyond the adrenal diagnosis, and the treatment is very different than neuroendocrine tumors. So you can have, so the typical chemotherapy that is used is mitotane, which is directed against the hormones that are secreted, and this chemotherapeutic drug combination. On the other hand, neuroendocrine tumor treatment is like totally different. You are more likely to see treatment with somatostatin analogs, and there are a variety of other therapies that are available. But this chemotherapeutic regime is not used for neuroendocrine tumors. Okay, let's do this case, and then I will stop for some questions, because this is sort of related to the case that we were just looking at. So this is another pitfall that I wanted to point out. Whenever you make a diagnosis of neuroendocrine tumor, especially based on a metastatic setting, like in the liver, you should always keep in mind that it's a good idea to get a keratin stain along with it. So I showed an example of a synaptophysin positive tumor, which looks like neuroendocrine tumor, but was adrenocortical carcinomas. And adrenocortical carcinomas typically are keratin negative, or just weakly positive. And here's another tumor which can be very close mimic of neuroendocrine tumors. So this is a 40-year-old male, abdominal mass. It was not clear from the imaging where it was arising, and it was thought to be possible pancreatic origin. And here you can see the morphology. It has got these nests of tumor cells. Once again, got a polygonal cell look to it. Looks very much like a neuroendocrine tumor. I think you can also consider that it could be a hepatocellular carcinoma, but very much reminiscent of a neuroendocrine type morphology, uniform tumor cells with nested kind of appearance. And here's the chromogranin synaptophysin, which is both of the stains were diffusely positive, and Ki67 proliferation index was 7%. So once again, the consideration here in this case is, are we dealing with a grade 2 neuroendocrine tumor or not? And the keratin, once again, is negative in this case, just like in the previous case I showed you. And we have the same diagnostic considerations to go through. And I show you this table again and again. So we are in the keratin negative category. So it looks like a neuroendocrine tumor based on the morphology and staining pattern, but we are in the keratin negative category. So you have to consider some of the other tumors which are on this list. And you always have to keep this tumor in mind, which is a paraganglioma. Metastatic paragangliomas were thought to be common, but now we know that increasingly paragangliomas, especially the ones that occur in the hereditary setting, they have a higher propensity for metastasis, and these often occur in the younger patients. And this classic textbook picture of this Zell-Borden or tight nests of tumor cells separated by this rich capillary network. That's a classic textbook description, but you often don't see that, especially in the metastatic setting. And if you do S100 stain, it can help in highlighting the sustencular cells, which can surround these nests of cells. But just like the morphology may not be classic in the metastatic setting, you may not get S100 staining in the metastatic setting as well. So that's also not very reliable to make this diagnosis. So you have to have a high index of suspicion, keep the clinical setting in mind, the morphology, the fact that keratin is negative in the context of positive neuroendocrine markers, and you can always get S100. It may or may not be helpful in the metastatic paragangliomas. Now, it's very important to keep paraganglioma in mind because a significant percentage of these occur in the hereditary setting. And one of the settings that I just wanted to mention today was the setting where you have paragangliomas because of loss of function of this enzyme, which is the succinate dehydrogenase. So this is one of the Krebs cycle enzymes, and it has several subunits. You can see SDHA, B, C, and D. And the reason that it becomes important from the pathology point of view is that there's a immunohistochemical assay available for the SDHB enzyme, and the paragangliomas that occur in the setting of mutations in the SDH enzymes can be detected by SDHB immunohistochemistry. So they will show loss of SDHB. So irrespective of the mutations being in any of these subunits, the SDHB is lost. So that can be a very useful assay for detection of these tumors in the hereditary setting. Here's an example of SDHB stain. This is normal. So this paraganglioma shows the strong cytoplasmic staining, which is the normal pattern of staining. So if it occurs in the hereditary setting, you will see a loss of this cytoplasmic staining in the tumor cells. So once again, let's examine from the treatment point of view, like why is it important to distinguish paragangliomas and neuroendocrine tumors? And once again, the reason is that the treatment that's offered is very different in both the cases. So for metastatic or unresectable paragangliomas, the chemotherapy that is used is this combination is different than what's used in neuroendocrine tumors, and more recently, a more targeted therapy which stops the it targets the production of hormones by the tumor cells has been approved by the FDA. And I'm not sure whether it's fully established as a standard protocol, but I think this is used in cases which are refractory to treatment. On the other hand, metastatic neuroendocrine tumors, as we talked about, are treated with a variety of modalities, but not by the chemotherapy or the options that are used in paragangliomas. So I've highlighted several tumors that are keratin negative and can resemble either HCCs or neuroendocrine tumors. And if you keep them in mind, the diagnosis is not that difficult because they have very characteristic immunohistochemical profiles. So before I go to the next case, let me pause and see if you have any questions. I was told that you can unmute to ask the question, or if there's anything on the chat.
Okay. Can I come in here?
Yes, go ahead, Vanita.
So, lovely cases, wonderful cases, packed with life lessons. And I think you hit the nail on the head when you say that these keratin negative differentials, they are real pitfalls, and they can totally mimic HCC, and they should be kept in mind. And I think that your pearls of wisdom are really, really going to be useful to everyone who's listening, and especially when you emphasize that the treatment should be kept in mind. I have a question regarding neuroendocrine marker positivity in HCC. So sometimes the hepatocellular markers don't turn up, but neuroendocrine markers are focally positive, or so that positivity we understand can be seen to some extent in HCCs also. So how do you think we should approach? Suppose there is a focal synaptophysin positivity, a weak marginal chromogranin positivity, and none of the hepatocellular markers light up, but there is mitosis, and you on morphology favored HCC, but now the neuroendocrine markers are positive. So how far do you carry it?
I think it's a very important problem that we face in especially in the metastatic setting, that synaptophysin and chromogranin or sometimes, especially synaptophysin, is sometimes focally positive, and in some cases it's even more strongly and more diffusely positive. And it occurs both in tumors which resemble HCC and even in adenocarcinomas. And sometimes we are faced with situations where we just can, based on morphology and staining, we can only say it's a poorly differentiated carcinoma and we can't go further. And then we see the synaptophysin staining, which is patchy, and chromogranin is in most cases negative in this setting. And the question whether it's a neuroendocrine versus just a poorly differentiated carcinoma, whether it's HCC or some other poorly differentiated carcinoma, can be extremely challenging. So how to approach that? So if it's in the liver and hepatocellular carcinoma is a diagnostic consideration, then you just have to go down whatever tools that you have in your arsenal. So if you have, let's say, only used hepa and arginase in your first round, then you have to just use whatever else you have in those uncommon cases. So if I have a case which I think could be HCC based on morphology and maybe the clinical setting of cirrhosis, but it's not marking for the typical marker, then I just go down and use everything that I have. And now we also have albumin in situ hybridization that we're using in addition to the hepa, the clopicin, arginase, polyclonal CEA. The markers which have lower sensitivity like AFP and CD10 in a small subset of cases, I've even used those because if the suspicion is very strong that it's HCC.
I agree.
Now, from the neuroendocrine angle, you can also use insulinoma-associated protein 1, INSM1, which is available.
Yes.
If there's a doubt about neuroendocrine tumors, and I know a lot of labs in India have that marker, available. So that's another possibility. But there will be some cases which you will not be able to resolve, even if you do everything. And the other markers for neuroendocrine carcinomas like retinoblastoma protein, like loss of RB, if you see that, it will favor neuroendocrine. So you just have to go by the morphology and clinical setting and add stains. And in some cases where you reach a dead end, you just have to say it's a poorly differentiated carcinoma. And further subset in those cases, molecular profiling with sequencing can suggest if the mutational profile is suggestive.
Okay, wonderful. We have one question, if I'm allowed to ask. So, Dr. Gandhi is asking how do you distinguish between CK19 positive HCC versus mixed combined cholangio HCC versus hepatoid adenocarcinomas?
Yeah, that's a very loaded question. So let's first address the first part of it, CK19 positivity in HCC versus an adenocarcinoma or a cholangiocarcinoma. So if you see the criteria for diagnosis of combined HCC cholangiocarcinoma, it requires two morphologic components. So you have to have a component of HCC and a component of a cholangiocarcinoma or adenocarcinoma, and then you confirm those based on immunohistochemistry. So if the tumor looks like hepatocellular carcinoma, it stains like hepatocellular carcinoma, and just happens to have positivity with CK19, CK7, or MOC31 along with it, then it does not meet the criteria for a cholangiocarcinoma or a mixed or a combined HCC cholangiocarcinoma. So what do we want to see to make sure that there is a cholangiocarcinoma component along with the HCC? So what we want to see is, in the best case scenario, we want to see well-formed and discrete glands in fibrous stroma. I know if you see that, then it's pretty straightforward. If there's a more poorly differentiated component and you do not have well-formed discrete glands, then one of the forgotten things often is mucins. Always look for a mucin stain. So let's say even mucin is negative, and you have a poorly differentiated component. Then what we would like to see is a CK19 or CK7 strongly positive and negativity for hepatocellular markers in that component. So those are the things that we're looking for a definite diagnosis of combined HCC cholangio. So two distinct components. And as I mentioned, there will be cases where you will reach a dead end. You will just not be able to say for sure whether an additional cholangio component is present or it's a poorly differentiated carcinoma, which way to go. And in those cases, sequencing can be helpful because some of the changes that you see, genomic changes, are very distinct in HCC and cholangiocarcinoma. Like the mutations in the beta-catenin or TERT promoter mutations are very characteristic of HCCs, while in cholangiocarcinoma you see a variety of very typical mutations like IDH and FGFR2 fusions and so on. So if you have characteristic abnormalities, that can help.
And the second thing, so do you think combined is now more in the category of HCC only? So does it, because molecularly, usually it shares molecular profile with HCC, the combined HCC cholangio. So do you think it fits more with, and we need not break our heads with the CK19 positive stem cell HCC versus poorly differentiated combined?
Yeah, so you can view it from two different angles. So one is the angle of pathogenesis of how the tumor is, where is the cholangiocarcinoma coming from. So in those, from that angle, it's possible that the cholangiocarcinoma arises as transdifferentiation from HCCs. But from a practical point of view, you have to distinguish those because, as I mentioned earlier, the treatment is what's important. The treatment for, if you have a cholangiocarcinoma component, whether it's just cholangiocarcinoma or as a part of HCC cholangiocarcinoma, the treatment is very different. And those patients, depending on what the clinical setting is, if let's say the clinical setting is the patient can be transplanted, has cirrhosis, at least in the US, the diagnosis of cholangiocarcinoma or combined HCC cholangio will virtually exclude the patient from a transplant because the risk of recurrence is much higher. And there are studies now that may change in the future, but at present at least. And similarly, the chemotherapy that is used for a cholangio component, whether it's a cholangiocarcinoma or HCC cholangio, these patients may be offered chemotherapy either after surgery or even after transplant sometimes. And that chemotherapy, like the gemcitabine-based regimens, are not used in HCCs. So from a practical point of view, it still is a challenge, and we have to focus on distinguishing HCCs from HCC cholangiocarcinomas, at least for the time being.
And
the other question, yeah, you go ahead.
Is there a cutoff of the glandular component? Sometimes there is a peripheral atypical ducts, which are, we keep on discussing whether it's a malignant glandular component or just a very extensive ductal reaction at the periphery. So is there a cutoff, like for some of the combined tumors, for other systems we have cutoffs for a substantial. So we know WHO just says that recognizable definite glandular and a definite hepatocellular component, but do you think a cutoff any recognizable glands? How can we make this easy?
Yeah, so that's a question that often comes up about the cutoffs, and there are some cutoffs that have been proposed, especially in pancreatic tumors, that to call it mixed, you have to have 30%, and that 30% number was pulled out of a hat. It has no data backing it that 30% should be a mixed and or 25% is not a mixed tumor. So in the liver, there is no such minimum criteria for diagnosis of HCC, a combined HCC cholangiocarcinoma. And the reason that there is no cutoff is that there is no data to support any cutoff. So we don't have outcome data to say what percentage of cholangiocarcinoma will be significant. So if you have a very minor component, like the examples that you were giving, so let's say there's a tumor which is predominantly HCC, and there is focal glandular differentiation, and you have convinced yourself that that is malignant, it's not ductal reaction at the periphery, then the way I've handled those cases is that I would say that it's a hepatocellular carcinoma with either focal glandular differentiation or a minor component of cholangiocarcinoma. And the surgeons and oncologists will kind of take that into consideration So if you say there's only 5% cholangiocarcinoma component, it may not trigger the treatment that is typically used for cholangiocarcinoma. But there is no such distinct cutoff. And in these cases, the management will have to be based on the individual patient and the clinical setting. We can only state what we see in these cases and say that there is no definite cutoff data to support one versus the other diagnosis. The other question that was raised before was about hepatoid carcinomas, which I did not address. So hepatoid carcinomas are, they're rare tumors which by definition arise outside the liver, and their stomach, pancreas, a wide variety of sites have been described. And as the name indicates, they look like HCC, and that's why the name hepatoid, or at least they have a component which looks like HCC. They may or may not have an associated glandular component with them. So they are referred to as either hepatoid carcinomas or hepatoid adenocarcinomas sometimes. So if you have a hepatoid carcinoma, it is indistinguishable from HCC, and that's by definition. So both by morphology and immunohistochemistry, it shows hepatocellular features. So there is no way, based just on the hepatocellular markers and morphology, that you can distinguish hepatoid carcinomas from an HCC, because they are by definition identical. So the features that help are that, of course, by definition, hepatoid carcinomas arise outside the liver. So if there is no tumor in the liver, then you know that it's not HCC. And it's in rare instances when you have a hepatoid carcinomas which can metastasize to liver, that's extremely rare, but it can happen. And in those cases, this difficulty may arise. I've had a couple of cases in which the primary tumor, the hepatoid carcinoma, was in the colon, and those tumors showed very strong staining for CDX2, which is not a definite for the diagnosis, but with all the other context, it favored that it was a hepatoid carcinoma. But in general, it has to be a diagnosis based with a combination of clinical features, the setting. If you have a large gastric mass, even if it is metastasized to the liver, if you have 2 or 3 liver nodules and a large gastric mass, then it's most likely that it's a hepatoid carcinoma from the stomach and not an HCC which metastasized to the stomach. So you just have to keep the clinical context in mind to make this diagnosis.
Great, wonderful.
Okay, so shall I proceed?
Sure.
Okay. So I talked to you about a variety of tumors which are keratin negative, and we also saw neuroendocrine marker positive tumors like adrenocortical and paragangliomas, which are keratin negative. So to wrap up that discussion, let me show you this case, which is a 64-year-old with a liver biopsy. And the imaging also showed that there was a 3-centimeter pancreatic tumor, and that was thought to be the primary site, and liver was thought to be the metastasis. And here you have the tumor, low power view. You can see there's abundant fibrous stroma in some portions. Here you can see these very well delineated nests of cells, maybe even some acinar or glandular-like configurations. And here's a closer view of the tumor cells. We're showing this kind of nested, you can say, trabecular appearance in some places, and they have this moderate to abundant cytoplasm. Once again, that kind of polygonal cell look to them, and you can consider, based on this morphology, that this could be a neuroendocrine tumor, and synaptophysin and chromogranin were negative, were both patchy positive rather, and there was a pancreatic mass, so this could be a metastatic pancreatic neuroendocrine tumor. The hepatocellular markers were negative in this case, and as opposed to the other cases that we were seeing, the keratin is positive here. So we are not in the keratin negative, but keratin positive category, and markers of neuroendocrine differentiation being positive in this case. And then this stain was done, which actually gave us the correct diagnosis. This is not a neuroendocrine tumor. This is trypsin stain, and this was a metastatic acinar cell carcinoma. This is another tumor that should keep in mind when you see a positive staining for neuroendocrine markers. In a vast majority of cases, synaptophysin and chromogranin are only focally positive. So, less than a third of the tumor cells will typically be positive in acinar cell carcinoma. But they can morphologically very closely resemble neuroendocrine tumors. So if you pay attention to the morphology, you may be able to see some of the tumor cells which have this granular cytoplasm, and these are the zymogen granules. And if you do a PASD, they will highlight these granules. But the PASD may not be very sensitive for this, and it's trypsin or chymotrypsin that should be obtained to make this diagnosis. In the metastatic setting especially, you may not have a prominent acinar architecture. It may be more nested and sheet-like. One of the very typical features in acinar cell carcinomas that you'll read, especially in textbooks, is that it has very large prominent nucleoli, which is true in most of the cases. And it is said that the nucleoli are so big that if you stare at them, they almost stare back at you. And the feature to keep in mind is that prominent nucleoli may not always be very clearly apparent, especially in metastasis. In fact, a few cases that I've seen in the last couple of years, none of them had the classic acinar cell prominent nucleoli in the metastatic setting. And as I mentioned, it's the trypsin and chymotrypsin that makes the diagnosis. So once again, you may ask the question, like, what's the importance of making this diagnosis as opposed to that of a metastatic neuroendocrine tumor? Well, acinar cell carcinomas have much more aggressive clinical course than well-differentiated neuroendocrine tumors. And the treatment in acinar cell carcinomas is just like a ductal adenocarcinoma, so the same chemotherapy is used. So the treatment is very different from neuroendocrine tumors. In terms of the molecular profile, around 10 to 20% of acinar cell carcinomas will show fusions or indels in the BRAF gene. And this is not the typical BRAF V600E mutation that you get in a wide variety of tumors. You get that in colon cancers and thyroid tumors and a variety of other settings. That's a hotspot mutation, but that's not what you get in acinar cell carcinomas. You get this BRAF fusion. In fact, I had a case in which an large abdominal mass was biopsied, and it just showed kind of the morphology would resemble neuroendocrine tumors, but it was much more atypical. And the acinar cell carcinoma was actually not even thought about in that case till it was sequenced. And once the BRAF abnormalities were noted, then trypsin and chymotrypsin were done, and they were diffusely positive in those tumors. So sometimes it's the other way around, that now the molecular profiling is giving us clues on how to work up tumors that don't show the classic features. Okay, let's deviate a little bit and look at a slightly different category of tumors. So this is a 32-year-old with a large liver mass which was detected during workup for abdominal pain, and a core needle biopsy was obtained. So here is a portion of the liver biopsy, and here you can see just some ductal reaction, mostly benign liver parenchyma with some just reactive changes. So this was around half of the biopsy showed these features, and here's the other half, which showed this. The low par view showed this, tumor which has this prominent fibromyxoid stroma, and you can see that the tumor cells are kind of encircling and entrapping the portal tract here. And here's a closer view showing you these individual tumor cells. You can see at this magnification that they have these large hyperchromatic appearing nuclei and somewhat spindle to epithelioid kind of morphology. And you can see abundant the fibromyxoid stroma here. So here's a closer view of the tumor cells. You can see some of them have slightly eccentric nuclei. Some of them are more elongated, around 2 ovals, kind of a mixed morphology in a myxoid stroma. And here there appears to be a vacuole in a tumor cell as well. and here almost like a triangular-shaped tumor cell. So kind of a varied morphology in a fibromyxoid stroma. And here's another tumor cell which has kind of this vacuolated appearance. So this sort of infiltrating the tumor cells and sort of this vacuolated appearance in a abundant fibromyxoid stroma, along with this immunohistochemical profile of strongly positive CK7. So you can see the ductules here, and the tumor cells are strongly positive for CK7. The other workup that was done was for other adenocarcinoma like TTF1 and so on and so forth, and all of that was negative. So it was the CK7 positivity and this kind of morphology that initially led, and there's another CK7 you can see positive in the tumor cells. So the initial course was that this was initially diagnosed as an intrahepatic cholangiocarcinoma because of the combination of features that I showed you. The patient was put on a gemcitabine-based chemotherapy because the tumor was thought to be unresectable. So 1 year later, there was no change in the size of the tumor. And since the tumor did not respond, it was sent for a second opinion. So we saw this case. So let's go back to the morphology of this tumor. And I would point out once again the very characteristic features here, which point to the diagnosis based on the H&E. So the characteristic loose myxoid stroma, sort of spindly to epithelioid appearing tumor cells, these intracellular, what looks like intracellular vacuoles, almost stellate-shaped cells here. So all this, whenever you see this appearance in a liver, this is a very characteristic of an epithelioid hemangioendothelioma. And these are what are known as blister cells, and these are abortive intracellular lumina, which appear like vacuolated cells and were mistaken in this case for vacuolated epithelial tumor cells. And of course, CD31 was strongly positive. And this case also highlights the pitfall of keratin stain, including CK7 and pan-keratin. And these stains can be positive not only in vascular tumors, but virtually any mesenchymal tumor. So if you take leiomyosarcomas and other sarcomas, just less commonly, but in rare GISTs, you can see some patchy keratin staining. So just based on keratin staining, you should not be diagnosing tumors, which especially with these single cells and as epithelial. And angiosarcomas as well as epithelioid hemangioendothelioma are well known to not only be just focally positive, but diffusely and strongly positive, especially with pan-keratin. The clues to the diagnosis of epithelioid hemangioendothelioma are its zonation, which may not always be apparent, especially in a needle biopsy. But if you have a resection, the zonation is very characteristic. So you see a myxoid hypocellular stroma in the center with very few tumor cells, and as you go away from the center, it becomes more and more cellular with infiltrating cords of cells, I showed you. And then at the periphery, you see that the tumor cells are infiltrating along the sinusoids in the adjacent liver. So this zonation is a very characteristic feature of this tumor. Now, this tumor recently has been shown to have some very typical translocations. So the two of them are listed here. The first one is far more common, and what it leads to is overexpression of this CAMTA1 protein. And immunohistochemistry for CAMTA1 is available, and that can help in challenging cases to establish the diagnosis of this tumor. And the second translocation is much less common. And in these tumors, you have overexpression of TFP3. So here's an example of an epithelioid hemangioendothelioma. And you can see that these infiltrating cords of tumor cells, abundant stroma here. And this is a CAMTA1 stain, which is showing strong nuclear staining. So this can be very helpful in, especially if you have small biopsies or more limited tumor, you have strong keratin staining. But in most cases, CAMTA1 is not really needed because with the morphology and positivity for vascular markers, you can do CD31 or one of the transcription factors like ERG, and those can clearly establish endothelial differentiation. And you really don't need the CAMTA1 for diagnosis in vast majority of cases. Okay, let's move on and look at another somewhat related case. This is another young patient, a 33-year-old with hepatomegaly, ascites, and jaundice. Workup for the liver disease was negative. Extensive workup was done. There was no hepatic or extrahepatic masses, and specifically imaging was done to even rule out any vascular diseases like venous artery obstruction. There was no evidence of heart disease. No portal vein, no thrombosis was noted. And here's what the liver biopsy showed. This is a very low power view, a very fragmented biopsy, and low power you can see that this may be either artifact or these are dilated sinusoids. Let's take a closer look. And I remind you of the history that there was no liver mass on imaging. So here is a closer view of these. It was a very fragmented kind of biopsy. And it does look like the sinusoids are more prominent here, even though it's kind of looks like the biopsy is falling apart. And here are the hepatocytes, maybe focally thick plates here, lined by these prominent sinusoids with prominent lining cells. Here's another view of the liver biopsy showing you the identical features. There's a bile duct, so there were portal tracts. So we knew it was not HCC just based on the fact that portal tracts were present throughout the biopsy, and very wide sinusoids here. I'm just going to show you this is the same view showing the same features, wider sinusoids, prominent lining cells here. Same features again, prominent lining cells with wide sinusoids. So when this biopsy was done, the initial diagnosis that was suggested was that this is venous artery obstruction because of the, these wide sinusoids. And this patient actually underwent a repeat biopsy because they could not find any underlying etiology. And the patient had, as I showed you, jaundice, ascites. The patient was actually very sick. And they did a repeat biopsy, which actually showed the same features as this one. And at that point, we saw the case. And what I want to point out to you here is that when you see this kind of case, the most important finding here is that you have to note the sinusoidal lining cells here. And here is the org stain, which is the transcription factor for endothelial cells. And you can see how it brings it out, how prominent these lining cells are. And even at H&E, you can sometimes even overlook that you have this diffuse proliferation of cells with endothelial differentiation lining these dilated sinusoids. And Ki67 shows that a very high proliferation rate, virtually all of them are positive in Ki67. And even P53 is highlighting nearly all of those tumor cells with strong staining. So this is a vascular tumor, and it's strongly positive for P53 with Ki67. And this is one of the patterns that's very well known with the angiosarcoma that can be easily overlooked on the biopsy. And on the imaging, you may not see a distinct mass in around 20% of the cases. And these are the tumors that will show sinusoidal infiltration and like a pileosis like pattern, like it was seen in this case. And then the more characteristic appearance of angiosarcoma, of course, is a mass forming, and then you see the typical anastomosing vascular channels. And if you see that, then the diagnosis is kind of more obvious. But it is the sinusoidal pattern that I really wanted to highlight. And this is a nice recent publication which discusses all the patterns that you see in angiosarcoma very well. So how about epithelioid hemangiosarcoma versus angiosarcoma? Now, in most cases, the diagnosis can be, the distinction can be made based on H&E, but both are vascular tumors, so they're going to show positive staining for the vascular markers, but the zonation, the blister cells, the lack of well-formed vessels in EHE, and the fact that the cytologic atypia is much more less prominent. And the CAMTA1 stain can really help if you really have to make that distinction. While angiosarcoma, the classic appearance, of course, is anastomosing vascular channels and destructive invasion with much higher Ki67 and diffuse P53. The reason that this distinction is important is angiosarcoma is extremely aggressive tumor, and it's virtually like a death sentence. While epithelial hemangioendothelioma is sort of shows intermediate aggressive behavior, the outcome is very variable. Some patients do very well with resection, while others cases can recur and metastasize, and you just can't predict based on morphology how the epithelial hemangioendothelioma will behave. And there have been cases in which the unresectable epithelial hemangioendotheliomas, which are confined to the liver, have even been transplanted. So that's the reason it's important to make the distinction between these two. Okay, let's move on to another case which can closely mimic angiosarcomas, and that's why I want to highlight this case. This is a typing error. This is not 251, but it's a 51-year-old woman who has NASH cirrhosis, and there's a liver mass on imaging which grew from 1.1 to 1.6 centimeters, and for that reason, and the fact that this was a cardiac background, there was a concern that this is hepatocellular carcinoma. So here's the morphology of this tumor. So here is the non-tumor liver here, and then here you can see the proliferation of tumor. It's very well demarcated from the adjacent liver. So let's take a closer look at the tumor. So you have these, diffuse arrangement of these tumor cells, which have a very uniform appearance. And it looks fairly vascular here. I'm going to show you a closer look. Here's a closer look at the tumor. So there's some variation in nuclear shape and size, but overall cytologic atypia is not striking at all, very mild at best. And you can see that there's very prominent vascularity in this tumor. It may even remind you of some of the tumors that I showed you earlier in the liver, like angiomyolipoma. So those are the kind of things that you should be thinking about when you see this sort of a streaming kind of a look without distinct cell boundaries. And here's yet another look to this tumor, showing you the cytologic features. And you can see the vessels here. Okay, so let's see how this tumor turned out to be. So of course the consideration was HCC cholangiocarcinoma based on cirrhosis, but it doesn't really look like one. And the immunohistochemistry also supported. It was keratin negative and Hepar negative. So the tumor, when it was sent to us for consultation, this tumor CD45 had been done. And based on that, hematopoietic neoplasm was raised, and CD3 was done and CD20 was done, and they only highlighted some isolated cells. And you can see CD68, a macrophage marker, is highlighting a lot of the cells, but you can also see that a lot of the background cells are negative. So it's probably a histiocytic infiltrate, which was CD45 positive and hematopoietic. It's not really a hematopoietic neoplasm. So what else? How about melanoma, angiomyolipoma? I have to admit that when I saw this case, I really thought that it might turn out into an angiomyolipoma. And HMB45 although was negative, so my theory didn't work. It was not an angiomyolipoma in this case. So let's go back to the morphology here. So you can see these very uniform tumor cells, and one of the features that was actually quite striking on the H&E, and I deliberately didn't point it out, is that a lot of these cells which are lining these vascular spaces are similar to the cells which are between the vascular spaces. And so of course that brings in the possibility that are we dealing with a vascular tumor? And then here's the CD34, which is strongly positive in the tumor, and so are the endothelial markers, ERG and FLI1, both transcription factors, very strongly positive in the tumor cells. So it clearly indicated that we are dealing with a vascular tumor here in the liver. And So these are the vascular neoplasms that occur in the liver. We have to choose between a hemangioma, epithelial hemangioendothelioma, and angiosarcoma. And certainly it doesn't look like the latter two. We already saw examples of that, and there's so minimal atypia. But you always have to be a little careful, As I showed you, angiosarcomas can show very, very well differentiated kind of morphology, but they still are very aggressive tumors, even though they may kind of look low-grade morphologically in some cases. So here's the P53, which really did not show much of nuclear staining, and the proliferation rate was also very low. And this is a tumor that I wanted to show you, which was recently described, and two different entities have been described, and they probably represent the same or very closely related entities. The one is a hepatic small vessel neoplasm, and the other name is anastomosing hemangioma. The case that I showed you had much more compact vessels, but many of these tumors actually have more anastomosing vascular pattern, like you see in this case. And you can see the adjacent liver is being infiltrated here, and that can easily lead to a mistaken diagnosis of angiosarcoma, that it's infiltrating the adjacent liver. And here's another of this tumor showing you this anastomosing vascular pattern. You can have vascular thrombosis and areas of infarction that have been replaced by fibrosis. So it can very closely mimic angiosarcoma based on its pattern. And here's a closer view. You often see this kind of hobnailed appearance of the lining cells. And the point to note here is that there is minimal cytologic atypia here. And it really helps to do Ki67 and P53 in these cases because the low proliferative rate will further support that you're dealing with either anastomosing hemangioma or a small vessel neoplasm and not dealing with angiosarcoma. And the fact that this was very well circumscribed in the case that I showed you favors that it is an anastomosing hemangioma. So the publication, one of the important differences between the two that has been stated is that hepatic small vessel neoplasm is infiltrative, while anastomosing hemangioma is well circumscribed. And anastomosing hemangioma has been described in a wide variety of other sites, including kidney and soft tissue, GI tract, and so on. And hepatic small vessel neoplasm is probably very closely related, if not the same tumor. But keep in mind that you have a benign vascular tumor which can have infiltrative pattern like you see in angiosarcomas. Okay, this is the last one for today. And going by the theme of keratin-negative tumors, I'm highlighting this case, which I've seen a few cases. This is still, I think, an uncommon or rare entity. 58-year-old with weight loss, and imaging showed a large gastroesophageal mass and large celiac nodes. A biopsy was done from this ulcerated mass, and it once again did not yield diagnostic tissue. And there were multiple liver lesions, and a liver biopsy was done. So here's the liver biopsy, and you can see benign liver and this side of the biopsy. And here you can see these tumor cells. Let's take a closer look at them. So here's like a sheet-like proliferation, no specific patterns of arrangement or architecture of these tumor cells. And even at this magnification, you can see that there's the marked nuclear pleomorphism. Here's a closer look showing you the marked nuclear atypia in this case. And in at least some of the tumor cells, you can see that the nuclei are eccentric. Let's see here. Yeah, it's a nice example. Eccentric nucleus, and has sort of a plasmacytoid look to it. And you can even think of plasmablastic lymphoma or rhabdoid kind of a morphology in at least some of the tumor cells. So basically what we are dealing with is sort of a very poorly differentiated malignant neoplasm, which is not giving much in terms of clues on which direction it might be differentiating. This is what the entire tumor looks like. Let's examine what the workup showed. It was keratin negative. hepatocellular markers were negative, and some of the other markers that were done for adenocarcinomas of different sites, they were all negative as well in this case. And MOC31, you can see there was some patchy membrane staining, which suggested that it could be an adenocarcinoma. And we know that there was a gastroesophageal large mass, which was the possible primary site, which also went along with the fact that this could be an adenocarcinoma, but it didn't really have any glandular differentiation. And even the keratin was negative, which was unusual. Here's the synaptophysin. You can see patchy synaptophysin, but it's pretty strong in some cells, but it's quite patchy. And as Dr. Monita raised the possibility earlier, you always are wondering, are we dealing with neuroendocrine tumor here or not? The chromogranin is negative, and I'm not showing you here, but even the INSM1 was done, and that was negative. And a wide variety of tumor markers for melanoma, for GIST, angiomyolipomas, vascular tumors, muscle markers, those are all negative in this case. So basically, we're dealing with a very poorly differentiated malignant neoplasm. And I actually didn't put it here, but EMA was focally positive. So are we dealing with a neuroendocrine carcinoma? Synaptophysin positivity kind of favors that, but the morphology doesn't kind of favor it. And even the RB was intact in this case. Could it be adenocarcinoma? It could be MOC31 positivity primary in the G junction. And secant negativity is kind of unusual. Pan-keratin totally negative in such tumors is a little unusual. So here is what I wanted to show you in this case, and that is a loss of a SMARC-A4. And you can see the nuclear staining in the background stroma, some endothelial cells, maybe some lymphocytes, but it's totally negative in the tumor cells. So what is SMARC-A4? So this is a part of chromatin remodeling complex, and I'm not going to go into detail. I'm myself not really an expert on this, of the chromatin remodeling with SWE SNF components. This is actually a very complex biology involved on how chromatin is remodeled based on a variety of components. I have listed only a few of them here. And mutations or loss of function which could occur because of methylation in one or more of these components can lead to a loss of chromatin remodeling, which plays a very important role in differentiation. And that's why a lot of these tumors tend to have this kind of undifferentiated look to it. So what are the common components of this complex? So some of them you're familiar with, SMARC-B1 or INI1. So we know that this has been very well described with proximal type epithelial sarcoma, a wide variety of other tumors, soft tissue tumors as well. And SMARC-A4, which was lost in this case, also known as BRG1. So it's kind of confusing, all these acronyms and then many synonyms for each acronym. But what I want to point out is that a loss of one or more of these components has been described in poorly differentiated or undifferentiated carcinomas in the GI tract at many sites. And I've particularly seen many cases now in the gastroesophageal region, but they've been described in the intestine and the colon as well. And this is not really any novel entity. It's just a poorly differentiated or undifferentiated carcinoma, which now we are finding out that the underlying molecular mechanism of it may be that it's a loss of one of these components. So the importance of knowing this is that these can show patchy synaptophysin, like I showed you, and these can be mistaken for neuroendocrine neoplasm. So that's important to keep in mind. Now, this case was keratin negative, but a vast majority of them do show some focal keratin staining. But on a biopsy, you may or may not have it. So, kind of a mixed morphology, maybe spindle. Some cases can be rhabdoid, but not all cases are rhabdoid. You would think with INI loss, the case may be rhabdoid, but some of them actually don't have rhabdoid morphology. And the variable staining can be seen with a wide variety of markers. Vimentin is usually positive, so that can lead you down the wrong path, that this is not an epithelial tumor. And these have uniform poor outcome. So once again, I want to emphasize that a loss of these components is not really specific for carcinomas of these sites. They are seen in a wide variety of tumors, soft tissue tumors, carcinomas at other sites. And there's no specific treatment for this, at least not yet. And I think the only importance of knowing this is not to mistake this for non-epithelial tumors, especially given the fact that keratin can only be focally positive or even negative in some cases. So you can always get an EMA, which is positive in some of the keratin negative cases, like in this example. So this is something to keep in mind whenever you are dealing with undifferentiated or poorly differentiated carcinoma, which may have arisen in the GI tract. All right, so I want to close with the story, and I've been fascinated with liver pathology, and it's not surprising that this fascination actually dates back to prehistoric times when human beings, when they were hunters, they were fascinated by liver even at that time. And this is a very interesting story where four guys were hiking with their dog in a small place called Lascaux in France, and their dog got lost. So while they were looking for their dog, they stumbled upon these caves, which had these prehistoric paintings dating back many thousands of years. And as you can see in this picture here, that there's a large liver that has been depicted here. So even the prehistoric humans, you can imagine their fascination when they opened these animals or killed them, and then they saw this large, red, beefy organ occupying the abdomen. And it's no surprise that liver was thought to be the soul, or the seat of the soul of the body for many centuries. And as we learned more and more about the biology, we have learned now that the liver has lost its central importance as being the soul of the body to maybe the heart or even the brain. But I think the fascination with the liver continues, both in art, in architecture, in popular culture, in history. And I'll just give you a couple of examples from the Indian context. I really didn't know what liver is called in Hindi, so I just looked it up. So these are how the words which mean liver, and kaleja or jigar are words that you often associate in the language with courage. So you can see that there's fascination of positive association with the liver, even in the language. And for those of you who are fans of cinema, you would of course remember these famous lines which were penned by Gulzar for this movie Omkara. Says that the liver is full of fire. So the liver continues to capture the fascination, and I hope it captures your fascination too, and you enjoy liver pathology as much as I do. So thank you again, and I'm around if there are any more questions.
Thank you, Dr. Kakar. We can see how much you love and are passionate about liver. And I thank you for sharing such excellent questions. There are such excellent cases. There are some questions. Regarding the clinical practice at your center, whether you get liver tissue in HCC patients, which are straightforward on radiology.
Say it again. I'm sorry, I missed the question.
So the question is whether in your clinical practice at your center, do you get liver tissue in the HCC patients, which are straightforward?
Oh, okay. So as we know, the guidelines from both the European and the US societies are that, especially in cirrhotic liver, if you have classic imaging, you do not need a liver biopsy to make the diagnosis. So our hepatologists here typically do not biopsy in cirrhotic liver unless they are atypical imaging findings. So most of the cases that we are getting are not classic. But this is a very long discussion, and I think that the practice should change. And there's a lot of editorials in hepatology, and there's a back and forth editorials also on whether liver biopsy should be done. If you see the advances that have been made in the targeted therapies and a lot of other sites, such as lung, The liver is really lagging behind. Nothing works in HCC. All the trials have been negative so far, and the tyrosine kinase inhibitors and most recently immunotherapy has given some benefit, but in general nothing works because HCC is being treated as one disease. HCC is not one disease. So unless you biopsy, you profile the tumors individually, you cannot come up with targeted therapies. So I am always advocating that biopsy should be done, but so far that's not the clinical practice. And I can tell you that the radiology categorization that is used for liver tumors, it's a LIRADS scoring scheme. So based on the LIRADS scheme, you can have a tumor which is categorized from 1 to 5, 5 being definite HCC. And I have a list of cases with me which have LIRADS 5, which are not HCC. So some of them are cholangiocarcinomas, a couple of them are FNH cases. So there are cases which are radiologically diagnosed as HCC but don't turn out to be. But I think still the sensitivity and specificity of LIRADS 5 is still quite high. So that's why in clinical practice, the biopsy is not done in these cases.
Okay, great. Another question is, alluded to earlier was hepatic small vessel neoplasm and distinguished it from angiosarcoma. There's a question how we differentiate it from epithelioid hemangioendothelioma.
Yeah, epithelioid hemangioendothelioma typically does not enter into the differential diagnosis because the morphology is very distinctive. So in hepatic small vessel neoplasm, you will have vascular channels that are anastomosing, they are better formed. The example I showed you is very unusual, in which they are very closely packed. Typically, you don't have myxoid stroma like you have in epithelioid hemangioendothelioma. Well-formed vessels are not seen in epithelioid hemangioendothelioma that you see in hepatic small vessel neoplasm. So the characteristic zonation, the blister cells, the myxoid stroma, so all those help in epithelioid hemangioendothelioma. While anastomosing vascular pattern with kind of a hobnailed endothelial cells without cytologic atypia would favor anastomosing hemangioma or a hepatic small vessel neoplasm.
Okay.
Just stop presenting so that we can see you.
Oh, okay.
So, two questions regarding IHC. One is about experience of CK20 expression in HCC. I think you covered that also with CDX2 positivity can be seen sometimes in. The question is it aberrant or does it have any clinical relevance?
Yeah, so both CK20 and CDX2 can be positive. I think it's around 5 to 10%. I've seen a few cases. I don't know of any clinical relevance of CK20 staining. And I've seen it in cases which just look like HCC. And I wouldn't have done it. Somebody did it and sent it to me. That's why I saw it. But yeah, it's good to keep in mind that you can see that.
Okay. It's regarding trypsin stain. In the experience, this is Dr. Paramita Roy. She's asking that you showed a brilliant trypsin stain, but her trypsin is always patchy and weak. So does it always work, or do you have any recommendations regarding clone or any tips regarding the behavior of this antibody?
Yeah, I agree that the antibody does behave in a finicky way sometimes. So in our lab, my experience has been that it worked pretty well for many years, and then suddenly it started staining everything else also. And then we had to re-standardize it. So what we have done as a kind of a measure to address that is that we also have chymotrypsin. And chymotrypsin has given very good results. So if we are strongly suspicious of a tumor, you can get either of those two stains, and if you're not very happy with it, you can get the other one too. So that's one solution, that you can get chymotrypsin. If you want the clone and all, I can send it to you. I don't know offhand.
Okay, great. Question is regarding, do you advocate liver biopsy from mass as well as from neighboring liver?
I would strongly advocate it, but it doesn't happen. In vast majority of cases, that doesn't happen.
Yeah.
But yeah, it would certainly be a good idea to do it uh, to get an idea about the background liver, it would be great.
Yeah. Okay, so the question is about the behavior of hepatic small vessel neoplasm, which I think you've already covered, and any anti-glypican 3 monoclonal antibody in the pipeline. So I guess the question is about targeted therapy in HCC, which
Yeah.
pointing so far. But do you have any molecular testing that you do as a routine for hepatic tumors?
Not as a routine. The oncologist will sometimes sequence anything, and they are just looking for targets if they can do anything. But basically, nothing. But I have done sequencing for diagnosis in selected cases. So if it's a poorly differentiated tumor in a cirrhotic liver, and if I'm not sure, even after doing all the immunohistochemistry, whether it's HCC or cholangiocarcinoma, and I know that there will be treatment implications. So I have sequenced those cases. And similarly, at the benign end of the spectrum, if you're not sure whether it's an adenoma or HCC, and in some cases it can have an implication. If it's going to be resected anyway, then there's no need to do molecular analysis. But if it's a biopsy and patient is either refusing treatment or there are multiple lesions and it will impact treatment, then those I have sequenced. And it can be helpful if you see beta-catenin mutations or TERT promoter mutations, it can be helpful in that setting.
Brilliant. Those are the questions that we had. Thank you so much. I wish we could go on and on. I enjoyed all your cases, and they were packed with pearls of wisdom and really very useful and things that everybody should watch out for and not take HCC for granted or lightly. Thank you so much, Dr. Kakar, and I hope to see you again sometime on this platform. And thank you, Dr. Nadeem. Over to you.
Thank you so much, both of you, Dr. Manita and Dr. Kakar Sanjay. We'll be going to sleep, and he really has to work whole day.
Yeah, my day is just getting started.
Just getting started, and we are almost on the bed. There was one last minute question which I thought, what is the relevance of molecular classification in our current practice? Which was just last typed in. So
yeah. So the short answer is it's not important right now. And there has been prognostic importance with proliferation class and so on. S1, S2, S3 based on gene expression profiling, and so there are several classifications, genetic classifications of HCC that have been proposed. None of them are clinically relevant at this point in time.
yeah, I think now we'll close. Before that, let me announce 3rd February is the next lecture of Dr. Kakar. And in between that, in January, we have some Dr. Dhanpat Jain from the same group, the group which you showed us.
Yeah.
And I will just close on one small note. Dr. Manita had introduced to Dr. Kakar and all his academic excellence. Let me tell you, Dr. Kakar is an excellent debater, a fantastic person to do dumb charade. We have won many, events in PGI, and he plays excellent cricket. He's a fantastic badminton player and a tennis player. So he's just not all about liver. It's much beyond liver. So thank you, Sanjay. So nice of you for consenting, and thank you everybody who joined us and stayed till 10:30 in the night. Thank you so much. God bless everybody. Good night. Good morning to you.
Thank you. Yeah, thank you, Dr. Munita, and thank you, Dr. Nadeem. This has been a pleasure, and thank you all.
Take care. Thank you. Bye bye.
Okay, bye.
Bye bye.